This is Dr. Daniel Laroche. I'm going to talk to you about a novel modified glaucoma intraconal retrobulbar tube technique. These are my disclosures. So retrobulbar tube shunt placements have been shown to be efficacious in lowering intraocular pressure. We previously reported our initial case using a retrobulbar tube. This was a technique that we used with a tube extender and Ahmed valve, and we were able to successfully get retrobulbar aqueous collections and show retrobulbar aqueous fluid delivery to lower intraocular pressure. You can see here a retrobulbar bleb there. The purpose of this report is to report 1 month results in 12 patients with a new Laroche retrobulbar intraconal glaucoma tube shunt technique using a modified Ahmed Clearpath 250. We have 12 patients. Pre-op mean IOP was 22 on 3.54 medications. Advanced glaucoma, mean visual field was minus 19.53. The mean age was 72. All the patients were pseudophakic, and the tube was inserted into the ciliary sulcus to reduce the risk of corneal decompensation. You can see here this video where we create a supratemporal conjunctival peritomy. The patients are blocked. Westcott scissors are used to dissect, and then large curved Stevens scissors to access the retrobulbar space. This is an Ahmed Clearpath 250. I remove the suture and I cut the sides of the plates off and shorten the plate. You don't need to have all this material. And we insert the small plate in the retrobulbar space with the complete length of the tube present. And then I trim the tube bevel down, and then I'll create a paracentesis, and fairly there, I'll insert viscoelastic into the eye, and actually I'm creating cautery over here, and insert viscoelastic into the ciliary sulcus here, and measuring with a caliper 1.5 millimeters back, using a 23 gauge needle to make an incision into the ciliary sulcus, placing the tube into the ciliary sulcus, and then I'll confirm the tube positioning in the anterior chamber with a cyclodialysis spatula, and I'll use a tenoproline suture and pass through the tube into the sclera, and that's 1 point of anchor. And tie that with a 3-1-1 knot, and I'll pass about 10 millimeters back another tenoproline through the tube, through the sclera, and that's my 2nd point of anchor, and I'll tie that off. Then I place a catena corneal scleral patch. This is a large, and I cut that, and I place it along the full length of the tube, and that covers the tubing, and it keeps the plate back. It helps to prevent the plate from migrating anteriorly, and I'll suture with 2 interrupted adovical sutures, and this is Tisel glue, and I'm gluing the conjunctiva and tenons, advancing it there, and then I'll create an inferior sclerotomy. Because you're going to have a low pressure in the beginning, there's a 30% chance of having a choroidal effusion. So I create a prophylactic sclerotomy with a 0.12 forceps and a crescent blade. I'll just remove a piece of sclera there, create a sclerotomy, close that with a vical suture. And then you're finished, and I'll leave viscoelastic in the anterior chamber, endocoat about 50% into the AC, and moxifloxacin and Kenalog. And then we're done. So post-op, we have short-term results 1 month. Mean post-op intraocular pressure is 15, and each number of medications 0.23. 1 patient required burping of viscoelastic post-op day 1. 3 patients required hypotony and shallow chamber requiring viscoelastic injection into the anterior chamber. So placement of the plate in the retrobulbar space does not lead to a subconjunctival bleb, but most posterior aqueous reservoir. Retrobulbar outflow of aqueous can be absorbed by lymphatics on the optic nerve and lacrimal glands. Additionally, so in conclusion, retrobulbar tubes as an initial intervention in patients with advanced uncomplicated glaucoma can potentially lead to good results. Further research is required with a larger number of patients and longer follow-up. And this is just a pilot report. Thank you.